everyone. I'm Heather Bouchard, and today I have the pleasure of speaking with Dr. Anthony Kontos. He is a professor and vice chair of clinical research in the Department of Orthopedic Surgery at the University of Pittsburgh and research director of both the Concussion Research Laboratory and University of Pittsburgh's Medical Center's Sports Medicine Concussion Program. His research is funded by Centers for the Disease Control and Prevention, Department of Defense, the NIH, and the NFL. He focuses on active treatments and clinical trials, risk factors, neurocognitive and neuromotor assessments and their effects, psychological issues, and concussion and brain health in military, pediatric, and sports populations. Dr. Kontos will be speaking at the upcoming SNS Symposium in Philadelphia this May. He will be giving a talk titled An Evidence-Based Approach to Multi-Domain Assessment. Dr. Kontos, thanks for speaking with me today. Can you
Thanks,
tell
Heather.
us
It's a pleasure.
Can you tell us a little bit about what a multi-domain assessment looks like for concussion?
Yeah, for sure. And I think there's this kind of fear that it's going to take forever to do a multi-domain assessment when really, the initial focus is to do a brief kind of wider net evaluation. And that's going to include, the basic structural elements of a clinical exam and interview, along with, patient reported or perhaps, some Confederate reported information, parent, et cetera, and then test results, right? And so it's going to cover everything from demographics, so age, gender, race, ethnicity, SES, the social determinants of health. But we've also found BMI to be important to look at, sport, and other factors. And then you look at, medical history, and not just concussion history, but also psychiatric, ADHD, migraine, motion sensitivity, because all those things kind of drive patients down certain pathways, right? And then really you shift gears into more what we consider the sort of classic concussion pieces, right? The symptoms. And, typically we look at like general symptoms, so more like post-concussion symptom scale or PCSI, like the SCAT tools for symptom inventories. But we really also want to dive into more sort of subtype or profile assessments, like what's available in the concussion clinical profile screening. So you're going to look at things like anxiety, mood, cognitive, migraine, headache, ocular, vestibular, sleep, and neck. And what you're really going to focus on there are more specific questions. So instead of headache, do you have a headache like the PCSS or PCSI, and how severe is it? We're going to ask you about headaches in the morning, or perhaps headaches when you're doing something like screen time or reading, and try to get a little bit better idea of different specific types of symptoms you have that match up with the profiles. And, the last couple areas we really focus on: psychological health. We want to dive a little deeper there, especially if we find any signal. And the usual suspects: anxiety, mood, and stress, but also things like somatization, which can play a huge role in how symptoms present and how a patient's recovery goes, and also behavior, what's observed, what's reported, what we see in the exam room. Sleep is important. We all know that, so I won't, beat that one too much. But also the impairments are critical, and we want to do testing that's as objective as possible, whether it's cognitive, computerized paper and pencil, but also, ocular motor screening, vestibular screening, tools like the VOMs and others. But we also want to look at things like dynamic balance and gait. And then finally, I think, one that gets overlooked a lot, although it's gotten more attention lately, is we really want to look at how patients respond to provocation via exertion, particularly dynamic exertion, to get a good idea of sort of where their symptoms are coming from, and where that signal is that's causing them, and what we might expect when they start to re-engage in activity. And like I said earlier, I think the goal is a wider net initially, and then you want to dive down or drill down into specific areas based on what you find, so you don't waste your time later. And then also you might want to use that information to refer to like neuro PT, vision, et cetera.
You mentioned that if you want to do brief assessments, so how long do these assessments typically take?
Well, they probably take a little bit less time than what I just spoke on, right? So they're usually, we have a sports medicine model here in Pittsburgh, and that was driven by, when Freddie Fu, who unfortunately passed away a couple of years ago, our former chair, and now Mac Hogan, they really believe in this, brief, broad assessment. And then once you find the signal, dive down into that and get more in depth there. But really, to be an efficient, multi-domain, comprehensive, team-based assessment. So it really takes, about an hour for everything. And that's our goal, is to get our patients evaluated within an hour, and then you do what's called a like an adjudication or determination of what does that patient have going on, and then what treatments are going to be recommended, what strategies, what interventions.
Yeah, it sounds really patient-centered.
Yeah, it is. And I think, that's really what we want to all do. That's our goal ultimately. Every one of us, everyone at the conference is to help patients get better faster and safely. And that's part and parcel to what we do. And I think it's important to really, and I hope to have time in my talk to look at some of the new recommendations that have come out as well, to look at what is the evidence for what's recommended maybe in the SCOTE 6, and then integrating that information into how we might evaluate this injury, and also considering things that maybe weren't included in some of the recommended tools, that certainly where there's evidence for those particular tools or assessments.
Yeah, so I'm curious what you kind of hope neuropsychologists will take away from hearing your talk at the conference, and it sounds like those recommendations will be a big piece. Can you talk a little bit more about that?
Yeah, that's a really good question, actually. And I think, ultimately we want everyone to walk out of the room, whether they're students, trainees, or longtime neuropsychologists or guests or whatever, with a better understanding of how to integrate multiple brief tools across these different domains, and kind of really integrate that information in a comprehensive, sort of intelligible way that can then be actionable, right? And it's also feasible. We want it to be something they can walk out and go, oh, I can do that in clinic. It's not going to take me 5 hours or 4 hours. It's going to be efficient with my patients. And ultimately, I also want everyone to walk out with an awareness of what the empirical evidence for the tools is. And I only have a brief amount of time to talk, but I hope to, obviously talk about everything that's referenced and evidence-based. And, some of the things sometimes that are evidence-based don't work their way into consensus. And then the question might be why. And then other times there are things that get included in practice and dogma that really don't have a lot of empirical support. And then the question again is why, and we want to evaluate what the evidence says and let that lead us.
Yeah, it sounds like a lot of great points, and I'll be excited to hear more about it at the conference. So, thank you again for taking the time to speak with me.
Thanks,
I
Heather.
want
It
to
was
make
my pleasure.
Yeah, I want to make sure everyone knows that if you want to hear more about this evidence-based approach, you can attend the SNS Symposium in Philadelphia this May. For those listening, if you want to learn more about the conference or register to attend, you can look at the SNS website for that information. It is the sportsneuropsychologysociety.com. And you can also follow SNS on Facebook and Twitter. We hope to see everyone there. Thanks.